Hi everyone, my name is Anna Hughes. I am a full-time ICU registered nurse, and today I will be proposing a practice change to increase nursing retention and reduce nursing turnover rates. While there are a variety of problems facing the American healthcare system today, there are two problems that seem to be the most daunting, and they are the two that no one quite seems to know what to do about. These two problems are the persistent problem of high nursing turnover rates and the problem that is newly on the rise which is the experience complexity gap. Nationally, the turnover rate for nursing is 17.1%. Here in Texas, that turnover rate is 21% among first-year nurses and 25% among all nurses. The experience complexity gap is a new phenomenon. It is what is affected by the turnover rate, but it is the experience that is leaving the bedside as the baby boomer generation begins to retire, and the increasingly complex patient population that we have with the increased incidences of chronic disease in our patient population here in America. So it is a problem because it is expecting new, inexperienced nurses to perform very complex quality care. This problem is not only urgent, it is very costly. So the cost of turnover is estimated to be anywhere from $37,000 to $58,400 per nurse. In 2018, it was estimated that high turnover rates cost hospitals anywhere from $4.4 million to $7 million annually. So included in those costs is the cost to onboard and train new hires, and that cost is anywhere from $97,000 to $105,000 typically per nurse. So you can see there how the numbers very quickly add up, which I'm sure you are all familiar with. As a whole, the evidence supporting which specific strategies are the most effective in improving nursing retention are hard to come by. There are a variety of studies that identify the problem and point to the importance of maintaining key relationships and safe practices and good work environments, but none identify the best way to do that. The above studies list previously implemented interventions that have had some positive outcomes, and so I'll go through a few. The three things that were implemented were mandatory breaks and improving break areas for nurses. That study found that doing so did improve retention at this specific facility and increase job satisfaction. The next study discussed the transition to practice programs. This has actually been a very successful intervention. I did find this study in particularly interesting. It talked about one hospital that had reported a 35% turnover rate among their new graduate nurses, and after implementing an RN residency program, that number decreased to 5.36%. So that's huge, and those programs are becoming more mandated across the board. And then improving nurse-leader relations. This was also very significant when it came to improving nurse retention. This study suggested different ways to do that were shared governance structures, allowing standing orders to increase autonomy for nurses, and then making sure that within staffing there was adequate staffing and adequate skills, which again goes back to kind of that experience complexity gap issue that we are coming in on. Yet despite all of these studies, despite the findings that different research is finding to show what is a healthy nursing environment and what does improve nursing retention, turnover rates still continue to rise. So that's what we want to stop. So even though we have all this information, turnover rates are continuing to rise, and that is our main problem. So what's the common denominator? This was a finding from an article in Forbes talking about what the upcoming generation is looking for in a job. The three things that were causing them to leave their current job were a lack of opportunity to grow, work-life balance, or lack of work-life balance, and then poor manager behavior. But what does this look like from a nursing perspective? Well, For one, it looks like giving them a vision. So when new nurses come to the bedside and they do not see a vision for themselves professionally at the bedside, they up and leave the bedside, whether that be for nurse practitioner school, CRNA school, or going to work for pharmaceutical sales or insurance. If they do not see where they're going and how they can be developed at the bedside, they will not stay there. Number two, while nurses do only work 3 days, they need to be assured that while they are at work, they are not concerned for their well-being, their license, or their ability to practice safe and quality care, because this is what will affect their work-life balance. They do have the adequate time off, but it's while they're at work. How are we caring for their work-life balance? How are we caring for their quality of life and the quality of their job? And then manager behavior also showed in many studies to be a very prominent factor in nursing retention, and so a positive relationship there, assurance that the manager will have the nurses back, will fight for them, and will advocate for them while they advocate for their patients. So the proposed solution today is a nursing-centered patient care model. So what would that include? It would include mandatory paid vacation time, benefit packages that improve over time and include a professional development plan, and then a mandated number of support staff per specified number of nurses, which we'll talk about later. The rationale behind this is, one, to avoid burnout. Even in good work environments, nursing can still be a high burnout profession. Provide nurses with a vision for their career, and allow nurses to do their job well by providing them with adequate support staff so they do not have to do more jobs than just their main job of being the primary nurse. Allowing them to still critically think and allow other support staff to step in and do the support activities. So for this practice change, we would like to utilize the Mayo Clinic Change Management Model. This model of implementation was chosen because this is truly what we are lacking. We are lacking a unified awareness, desire, and team of reinforcement to implement changes that are needed to preserve the career of bedside nursing. Our target audience for this practice change is not only nurses and nursing support staff, but also you as administrators, because we cannot accomplish what we need to accomplish without your help. For the implementation plan and timeline, what would that actually look like? The 5 specific action steps that would initially need to be taken for this care model would be, number 1, to mandate that PCT to RN ratio and begin hiring as soon as possible. Number 2, advertising and mandating that vacation time that we talked about. Number 3, hiring personal professional development coaches. Number 4, standardizing the benefits package and the progressional levels that would include. And number 5, pairing RNs with professional development coaches so that they can begin to see how they can grow professionally at the bedside or otherwise. Again, study after study showed that adequate staffing had a positive impact on retention and patient outcomes, which is why we would want to get that PCT to RN ratio established along with the staff that is necessary for that very quickly. So that would be a very important part of the implementation process. We estimate that this would, if done as efficiently as possible, could be executed over a 2-year time span. As with any new care model, there are strengths, weaknesses to each of them. So some of the strengths of this plan would be the affordability, which we will look at in a moment, and the potential to reduce both RN and PCT turnover, which is a huge cost to hospitals. Some weaknesses is that it does not necessarily solve the complexity problem. However, there are opportunities with that, is that if this plan is successful in building retention and retaining nurses, there's an opportunity to cultivate and maintain and rebuild that experience at the bedside that we are losing. Threats to this plan would be federal budget cuts, and just the ever-changing healthcare environment that we currently live in, and changes from the federal level that we may not be able to control. The evaluation plan for this process would look something like this slide. The metrics to be evaluated would be the effectiveness of care, timeliness of care, safety of care, turnover rate, nursing satisfaction scores. The critical indicators would be turnover rate, nursing satisfaction, patient safety and outcomes, work environment, and healthcare costs. And so these are the goal indicators that we would like to see happen. Obviously, if those do not occur, we would make changes as necessary. So what would this plan look like in action? It would look like quarterly feedback meetings between bedside RNs, management, and administration. This may be shared governance leaders or committee members, or selected RNs by management. Metrics would be monitored by administration, management, and assigned project leaders and implementators. And quarterly surveys would also go out to nurses and PCTs for more anonymous feedback. The projected financial benefits. So these are all estimated numbers supporting a medium-sized facility with approximately 120 full-time RNs. As you can see, if you remember in the previous slides, we talked about how the annual cost of turnover could cost a hospital anywhere from $4 to $7 million a year. So even with all of the implementations that we are suggesting, you can see very quickly that the money that this plan has the potential to save. So while you're essentially hiring more staff, you're actually saving money in the long term as we continue to reduce turnover costs. So the estimated savings after implementation would be $2,425,000. And again, the timeline that was previously shown was over 2 years, so that may be spread out a little bit more, but you would still achieve that break-even point and eventually be saving millions of dollars very quickly. So this is the end of our proposed nursing-centered patient care model. Thank you for your time, and look forward to discussing this more.